So good morning, good afternoon, or good evening, depending on where you're joining us from. I'd like to get started and wish everyone a very warm welcome to our virtual workshop, where the focus will be on reviewing progress on the global learning agenda for expanded contraceptive method choice for adolescents and youth. My name is Sherry Bastine. I'm a scientist working on adolescent sexual and reproductive health at WHO's headquarters in Geneva, and I'm so pleased to welcome you all to this session. The high level of interest in registering for this workshop has been really encouraging, and it's a pleasure to see some familiar faces out there, as well as some new ones joining us today from various parts of the world. So we are here under the auspices of the Full Access, Full Choice Project, USAID's Momentum Country and Global Leadership, and the World Health Organization and Human Reproduction Program. Other important collaborators include Save the Children, Engender Health, and Yield Hub. I'd like to acknowledge the leadership of Professor Eileen Spicer at UNC, as well as her colleagues Amelia Maitan-Jonetti and Lauren Lansing in organizing this convening. I would also like to acknowledge the substantive inputs to the planning and organizing of this workshop by Callie Simon from the Momentum Country and Global Leadership Project. Many thanks as well to all the presenters and facilitators. Not least, we are grateful to the Bill and Melinda Gates Foundation and USAID for the funding and support for the global learning agenda, and in particular, this convening. Our gathering today marks a significant step towards assessing and enhancing our collective efforts in addressing the knowledge gaps surrounding adolescent and youth contraceptive access and choice. In 2018, also under the leadership of Eileen Spicer, there was a concerted effort to map and prioritize the evidence and measurement needs crucial for improving access to and the use of an expanded range of contraceptive methods for adolescents and youth. This initiative was rooted in a strongly participatory process that brought together a diverse group of stakeholders, including NGOs, UN agencies, donors, and youth to develop the global learning agenda. Now, 6 years later, we aim to review the progress made against the 6 priority learning questions identified. And during the next 2.5 hours, we'll dive into findings from scoping reviews for each question and engage in discussions on what has been sufficiently answered, as well as what questions remain a high priority as we move forward. This workshop is the first step in a comprehensive process to develop an updated global learning agenda, and your contributions today will help lay the foundation for this vital work. So thanks again to everyone for joining. I'd just like to note that the program is structured to really maximize engagement through the use of breakout rooms and mural boards so that we can jointly identify priority evidence gaps to advance the research agenda. And just a few housekeeping issues to raise before we get started. Firstly, as you'll be aware, the meeting is being recorded, and the recording and presentations will be made available after the meeting to those who registered. Secondly, the chat is open, and we strongly encourage you to remain engaged with one another throughout the meeting via the chat function. It's great to see so many have already introduced themselves in the chat. Please do so if you haven't already. And finally, please remain on mute and off camera when the presenters are speaking. Without further ado, I'd like to hand it over to Eileen now, who will set the stage by further sharing information regarding the background and introduction to this global convening. Eileen, over to you.
Thank you, Sherry. So thank you, everyone, for joining us today for this virtual webinar, where we're going to examine together the progress that's been made on understanding some priority questions around adolescent and youth contraceptive method choice. This webinar, as Sherry mentioned, is supported by a number of organizations that are listed here on this slide, and we're thrilled to have our partners engaged in this process, as well as with support from the Bill and Melinda Gates Foundation and from USAID. This webinar focuses on a global learning agenda that we developed in 2018, as mentioned by Sherry, and I'll tell you a little bit more about that. And in this brief presentation, I want to just introduce that and provide the grounding for the development of it and how we came up with the priority questions and the meeting objectives for today. Next slide, please. Great. So in the late 2010s, there was increased interest and attention on focusing on adolescents and youth contraceptive use, including young people becoming a key focus of many of the FP 2020 country programs. At that time, there was the realization that we lacked depth of information on how to reach young people, as well as how to ensure that they had full access to a full range of contraceptive methods. This led to the development of our project that's called the Full Access, Full Choice Project that's funded by the Bill and Melinda Gates Foundation. And I'm not going to go into details on that project today. Excuse me. As a first activity of that project, we led a 2018, a 3-day technical workshop in collaboration with WHO, FP 2020, and the E2A project at Pathfinder to develop a global learning agenda on expanded method choice for adolescents and youth. At that workshop, a large number of learning questions were identified by participants. The workshop ended with a consensus-based prioritization exercise in plenary, with all participants voting on their top 2 learning questions that could be answered in what we called the short term, that is in the next 2 years or so, in the medium term, that is in the maybe in 3 to 5 years, and in the long term that might require a new project or new primary data collection. In 2018, there was the feeling that there were gaps in research evidence on adolescents and youth. And since then, there's been a big change, and we've learned a lot now. And at this meeting, we want to start to consider the priority questions and determine if we want to adjust them, consider more nuanced questions for moving the field forward, or look at different areas. So at this meeting, we will synthesize what we know from some rapid scoping reviews related to the priority questions and start the conversation for developing a new learning agenda. Next slide. So this is the global learning agenda that was developed at the 2018 meeting that we can add a link for in the chat. And hopefully you saw this as part of the meeting invitation. Notably, one of the things that came out that wasn't listed as our 6 priority questions was the need to define what we mean by expanded method choice. So as a first activity, we developed this definition that is ensuring that all individuals and couples, especially adolescents and youth, have the agency, information, access, and support they need to freely choose and obtain the contraceptive method they prefer in an environment free from bias or stigma. Next slide, please. At the time of that meeting in 2018, we were seeking questions that addressed areas related to expanded method choice for young people along a full continuum of learning. The meeting came up with 17 short-term questions, 12 medium-term questions, and 6 long-term questions that were identified. And you can see that in the global learning agenda. The prioritized questions are the ones we are focusing on here today, but there will also be a process to collect information on the other questions and identifying new priorities that Callie will talk about towards the end of the session today. Next slide, please. So at this meeting, our intention is to share from the rapid scoping reviews on the 6 priority learning questions and reflect on what questions have been sufficiently answered. These scoping reviews were not meant to be exhaustive nor systematic, but rather we sought to have a saturation of the findings and the lessons from these reviews. We then want, after we share briefly share the findings from these reviews, we then want to reflect on what questions remain important to take the field forward and consider new important questions. This will happen in hopefully dynamic breakout groups. Finally, we'll share the next steps for developing an updated learning agenda. Next slide, please. As we move forward, sort of beyond the current questions and into the next round of questions, previously we were focused on expanded method choice for adolescents and youth, whereas now the new directions and focus will be on adoption, continuation, and method choice as well, but specifically with a focus on adolescents. Next slide, please. So as we reviewed the 6 priority questions, I don't think we thought about this at the time when they were prioritized, but we did see an overlap in the findings, which related to the fact that 4 of the questions have overlapping components. In particular, the question about influencing factors on postpartum and post-abortion family planning, on who is influential in affecting young people's contraceptive decision-making, on what features of service delivery are attractive to young people, and the question on pathways to method choice often had overlapping components that I've listed here on the right, in terms of social and cultural norms that influence these things, myths and misperceptions, parents, peers, etc. I say that here because these will come out in the presentations, in multiple of the presentations, and they indicate the importance of considering young people through the multiple layers of influence and factors that we need to be considering. Next slide, please. So just briefly, this is how we will spend our time. Following this presentation, we will hear brief presentations on 3 priority questions. After those short presentations, we will break into breakout groups to discuss next steps related to these questions and priority for new or different questions. Then we will come back together to jointly review 3 more questions before breaking again into breakout groups. Finally, we will reconvene to discuss the lessons learned and next steps for creating an updated agenda on adolescent contraception, continuation, and expanded method choice. With this, I will invite our first presenter, Amelia Maytan-Jonady, to present on her priority question.
Thank you, Eileen. So my name is Amelia Maytan-Jonady, and I'm a research associate with the Full Access Full Choice Project here at the Carolina Population Center at UNC. I'll be presenting on short-term question 2, which is, what is the link between expanded method choice and adolescent and youth outcomes such as uptake, discontinuation, and switching? Next slide, please. So this question was in a way grounded in evidence that has shown that when you add a method to the method mix, or when an existing method is made available to a larger percentage of the population, an overall contraceptive use increases. So we wanted to look at how the introduction of new methods affects contraceptive use specifically among young women. Are these methods acceptable? Who are the new adopters? Are adopters switching from other methods? What methods are they switching from? And what is continuation like for these methods? So we decided to look at 3 methods in particular: DMPA subcutaneous or Cyanopress, the hormonal IUD, also known as the LNG-IUS, and the implant. Next slide, please. So for an overall summary, what was found, many studies were found about method introduction, but few studies focus on or call out adolescent and youth needs and outcomes. And when that did happen, it was mostly for studies on Cyanopress. So for Cyanopress, there is clear evidence of the acceptability and potential for Cyanopress to attract new and young users. For the hormonal IUD, there was some evidence of high satisfaction and continuation overall, including among young and nulliparous women. And for the implant, some evidence was found of better continuation rates among adolescents and youth who adopt the implant over a short-acting method. Next slide, please. So now I'd like to go into a little more detail about what was found for each method. For Cyanopress, many studies have established its acceptability among women, and its use has been increasing over time among married and unmarried women. It has also been shown to be attractive to younger users. In pilot studies, over 40% of new doses were given to women under 25. Cyanopress also adds value to the method mix by attracting new users, not just replacing old injectable users. Several studies show high rates of new users adopting Cyanopress. In a study using population-based data from Burkina Faso and Uganda, it was the first method used by a majority of users. And for those women who did switch from another method to Cyanopress, they had generally switched from a less effective method. A noteworthy attribute of Cyanopress is the ability to self-inject this method, but initially there was uncertainty about the acceptability of self-injection, particularly among younger women. At this point, though, the feasibility and acceptability of self-injection for Cyanopress has been well documented for all ages, and there is evidence to show that adolescents also have favorable attitudes towards self-injection. However, among adolescents, there were concerns raised about privacy at home with self-injection, especially for those who are unmarried. Continuation rates for Cyanopress are comparable to traditional injectables, but when Cyanopress is self-injected, continuation rates have been seen to be higher compared to traditional injectables, and especially among women 18 to 24 compared to older women. So moving on to the hormonal IUD, there's limited availability of this method due to cost and lack of trained providers. Evidence shows that there is potential for the hormonal IUD to attract new users, with 5 to 23% of users being new users, but it largely appeals to women who want to switch from a short-acting method to a longer-acting method. Continuation rates have been found to be comparable to continuation rates for other LARCs, and so is satisfaction rates. One study found that women under 25 were more satisfied with the method than older women. For adolescent girls and young women, reduced menstrual bleeding was seen both as a positive and a negative side effect, and there were mixed perspectives shared about their comfort with the insertion process. Overall, most hormonal IUD users are married, older than 25, and have children, but there is some potential seen for its appeal among younger users, as in Madagascar and Kenya, there was a notable minority of users who are under 25. And lastly, for the implant, increases in contraceptive use have been attributed to increases in implant use. Overall, implant use is higher among women over 25, with low use among nulliparous women. But a study in Kenya showed that there is interest in implants among women 18 to 24. And for those who adopted the implant, they had higher continuation rates than for those who chose the short-acting method. A study in South Africa found comparable discontinuation rates for the implant with the copper IUD and injectables. We did not find evidence specifically on adoption and continuation of the implant among adolescents and young women. So, next slide, please. So as Eileen and Sherry mentioned, we will be breaking out into breakout groups. Each group will be discussing a different set of questions. And so here are the 4 questions we'll be discussing for this learning question. The questions in green are common across all of the learning questions, and the 2 questions in maroon are specific to this learning question on expanded method choice and method introduction. So if you have any thoughts to share on these questions, please write them down for now, and then we'll have an opportunity to discuss these questions more in the breakout groups. So thank you, and I'll now pass the floor to our next presenter, David.
Thank you so much, Amelia. Good morning, good afternoon, good evening, everyone. My name is David Imbago. I am the director of the Yield Hub, and I will be guiding you through this second long-term question, which is focusing on youth participation in the topic of contraception. So you can see here the long-term question number 2, which is when young people design services, how are they changed? So we're focusing pretty much on the transformative aspect of youth participation. When young people are involved in program design, what is prioritized and how does this lead to improvement method of choice? Next slide, please. So first things first, when we talk about youth participation, youth partnership, meaningful adolescent and youth engagement, there are many, many topics, but we need to start defining it. And I'm going to share with you this definition, which comes from the High Impact Practices Brief. You can find it online as well. There are many, many resources out there, but this is the one that we are using for this presentation. So meaningful adolescent and youth engagement and partnership is defined as an inclusive, intentional, mutually respectful partnership between adolescents, youth, and adults, whereby power is shared, respective contributions are valued, and young people's ideas, perspectives, skills, and strengths are integrated into the design and delivery of programs, strategies, policies, funding mechanisms, and organizations that affect their lives and their communities, countries, and the world. So I know that this is a long definition, but I think that is important for us to start by having a common ground of what we're talking about here. So next slide, please. So here I'm going to explain quickly what is the evidence that we reviewed as part of this the project that we have been talking about today. So this was a review that was more inclusive and also included adolescents and youth comparing to other reviews, such as, for example, the WHO, the review which only included adolescents. So in this case, the scoping review undertaken by Full Access Full Choice Project for this question, we examined both quantitative and also qualitative studies. We included a study that focused on adolescents and or youth, as I said before, not only adolescents. There were 57 studies found, 18 rejected because of they were not they didn't have the scope of the research that we were conducting. Therefore, 39 studies were reviewed in more detail. Finally, several studies underway that may be informative in the future. And we're comparing the results to those undertaken as part of the WHO guideline development review on adolescent contraceptive. And we'll talk about it a bit more in the next slides. Next, please. Now, as I said before, there's also the WHO guideline development review, which is focusing only on adolescents. So this approach is a systematic review of studies with high confidence, for example, randomized clinical trials, or also lower confidence, such as observational studies. We're also focusing on studies where adolescents could be specifically examined. So that's the difference with the other review that we have conducted, which also includes young people. In this case, the studies that were included in the WHO review, there were no studies found that compare meaningful engagement to non meaningful engagement, and of course there are ethical concerns about this. For example, not including young people versus including young people, it has some nuances to the question. Then also adolescent engagement, often part of a multi-component study and not specifically examined. So usually youth participation is one aspect of a process, it's not necessarily just one thing that was examined in general. And finally, information about what was done to engage young people is often limited. And that's because I think that youth participation in general is still being discussed and evolving. So the question for this review of WHO is, does meaningful engagement of adolescents and or young people in the design, implementation, and or monitoring of programs led to increased contraceptive use or access or quality of care compared to programs with no engagement or no meaningful engagement of young people? Next slide. The summary of findings from this review is the WHO draft recommendation is that engaging adolescents is a good practice statement, so that is positive development. The scoping review shows it is possible to engage adolescent girls and young women as well. And finally, there are still gaps in understanding the outcomes related to engaging young people in the most appropriate ways meaningfully. I think that there are many studies that are engaging with young people, but meaningfully, I think that is the second question that we need to answer as well. Next slide. And this slide is a bit heavy on text, so bear with me, please. So we have here two comparisons of the results. First, on the left, you can see the WHO recommendations that we are reviewing still, is that adolescents should be meaningfully engaged in the design implementation of programs. So this is a good practice statement that I said before. And then on the right, we have some results from the Global Learning Agenda Review. And for example, most studies focus on how to incorporate young people and improve engagement, but do not focus on the outcomes of these engagements. So we know that this is a good practice, but we don't know what for. There's a lack of engagement of adolescents and youth in observation and reflection stages of the studies. There's also studies often focus on barriers and facilitators to adolescents. Youth engage, design, but do not report on effectiveness of engaging young people. So we're still a bit confused on what is the effectiveness of this. Youth engaged research is possible and has been undertaken in other fields, so there is promise for this. Youth-led programs found improves responsiveness to youth needs, but not assessed as related to health outcomes. So once again, we have great processes, but we are still unsure about the outputs and the outcomes. Resource and time intensive as well. Analysis of peer-led education programs show improvements in knowledge and attitudes, but little behavior changes. Some studies that engage youth do not clarify the level of engagement to determine it meaningfully. And finally, young people prioritize culturally appropriate research, peer-based, realistic, and entertaining programs that affect the effect on method choice and health outcomes remains a research gap. So we still have a long way to go to make more progress on this. Next slide. So for the breakout groups that I will be facilitated, for the breakout group that I will be facilitating, we have a learning question on the left, and then we will focus on these questions on the right. So to what degree has this question been answered, which is when young people lead, what are the things that are changed? Also, are there bodies of work that are missing to answering this question? What questions should we still ask ourselves for the next phase of the review? And what is needed to have answers to these questions in the next 3 to 5 years? So that's it from my side, and I'll hand it over back to Eileen.
Thank you, David. I realized that I failed to introduce myself after hearing David and Amelia introduce themselves. So I'm Eileen Spicer, and I'm a professor at the University of North Carolina at Chapel Hill and a faculty fellow at the Carolina Population Center. So the third question, before we break out into breakout groups that we're going to talk about, is this what we called a medium-term question at the time, which was about what can we learn from a pathway to method choice for adolescents and youth, what drives family planning decisions, and what makes an adolescent or girl or youth choose a specific method. Next slide, please. So to help answer this question, which is related to adoption of a method and barriers to contraceptive use and barriers to method choice, we did a scoping review as well that involved searching databases for key terms related to method choice, pathway, family planning, decision-making, adolescents and youth, among other related terms. We searched in Google Scholar and PubMed for relevant publications. We included both qualitative and quantitative studies that were trying to answer this sort of question for young people. Further, we used papers from the Full Access and Full Choice Project on the topic, including a very specific study, a qualitative study on adolescent and youth trajectories to method choice in Kenya that was led by Lisa Calhoun, who's on this call. Finally, the team reviewed relevant HIP briefs, including one on knowledge, beliefs, attitudes, and self-efficacy, as well as the HIP brief on economic empowerment to see if these had relevant resources. A total of 121 articles were initially identified, and 38 were rejected as they were not applicable on our deeper review. The remaining 83 articles were reviewed in more depth to see how and if they related to this question. Because of the broad focus of this question, we put our emphasis more on adolescent and youth decision-making and timing of adoption and method choice to answer this question. Next slide, please. So just first a brief summary of the findings, and then we'll dig a little bit deeper into them in the next slide. So as mentioned earlier in my introductory presentation, there are overlapping components and numerous key factors that influence young people's trajectory or pathway to method choice. This slide shows the key factors that broadly grouped that were found in the literature to influence decision-making, including temporal and life transitions, risk assessment, barriers to adoption and use, and method choice. I'll discuss each of these in the next slide. Next slide, there you go. So the temporal and life transition factors that influence method choice and adoption include age at first sex, and of course, relationship status at first sex, marriage and relationship status, and experience of a first birth. For example, a young woman who's having early or non-marital sex or first sex is likely to choose a different method, potentially condoms, than a young woman whose first use is after her marriage or first birth, when she might choose an injectable or a LARC. Some young women, particularly those who are not yet in union, are choosing whether or not to use a method and which method to use, including potentially abortion, based on their risk assessment of a pregnancy, STI, sexually transmitted infection, or HIV, and the response from their family that they might get if they're found out to be pregnant or even sexually active. This risk assessment is closely tied to the social and cultural barriers that young people feel for having premarital or non-marital sex, or even trying to prevent a birth. Each of these factors influence both the decision about sexual activity, decisions about whether to use a contraceptive method, and decisions about what method to use. Additionally, some young women are worried about side effects, and this might affect their decision to use or not use a method and which method to choose. Notably, these same social and cultural barriers also influence young married women who are expected to have a birth immediately following marriage. These social and cultural barriers are also found at the provider level when providers impose restrictions on young people's use based on their own personal perspectives. Additional barriers include gaps in knowledge about methods or access to methods among young women, that whether they're both married and unmarried. These are system-level obstacles, among other obstacles at this level. All of these factors influence the timing of adoption and which method is chosen at the time of first use, adoption, and continuation or switching. Specific method choice can be influenced by method features and related desires, knowledge of contraceptive methods, preference potentially for traditional methods, the frequency of sexual activity, source options available or source preferences, partner influences, location where the young person lives, their income, their social and relationship influences, and age, among many other things. Next slide, please. So I borrowed this figure. Not going to walk through it in detail, but just to show it's from Lisa Calhoun's paper on trajectories to method choice. I find that it's useful just to show what we're talking about here. So pathways or trajectories to method choice are influenced from different patterns and influences at different stages of life. As found in Lisa's analysis, some women are using a short-acting method as their first method at first or early sex, while others who first use a method after a first birth are more likely to adopt an injectable or LARC. This may relate to their increased access to these methods following a birth and being in the health system. Many of these influences and the prioritization of them may vary over the life course. So this is over the years. So information on these types of trajectories can be useful for considering programs for adolescent girls and young women, depending on if the program is targeting a young woman, an unmarried woman, a postpartum young woman, for example. There's just different timing that we need to be thinking about. Next slide, please. So for this learning question, we've pulled the two green questions again are the same across all of the learning questions. So we want to know, has this question been answered? And if not, which parts remain to be answered? And are there bodies of work that we're missing for considering these issues? As well as we want to potentially do a deeper dive into what do these lessons around pathways to method choice mean for programming? Do we need to have questions specific for interventions? And how does or can evidence around pathways to method choice influence program and policy design? So with this, I'm going to ask for the next slide, and I'm going to just briefly describe what we're going to do next. So we are going to head into the breakout groups in just a moment. There'll be 3 breakout groups that you'll be sent to these breakout groups. In the breakout groups, we will be using the mural board, and that will be explained as well. But I will say that because we're only doing 1 round of breakout groups on these 3 topics, we will send you after probably tomorrow or so, we will send you the list of learning questions and the list of specific questions related to each of these, because we know we targeted the invitation list for this. And so we know many of you will have thoughts and inputs on multiple of these groups, but you're only attending 1 at this point. So we will welcome your inputs and we will be requesting those afterwards, but we look forward to a lively discussion in the breakout groups where we're headed right now. So Lauren, please send us to the breakout groups.
Just checking to see that most are back now. Great. So I'd like to welcome everyone back to the main session. I hope you enjoyed some lively and stimulating discussions during the breakout sessions. There were some great points raised by participants in the group I joined on youth engagement, and that was really fantastic to see. So I'd now like to hand it over to my colleague, Dr. Neetu Sayeda, who will introduce herself and give the next presentation. Neetu, over to you.
Thank you, Freddie. So, hi everyone. I'm Dr. Saida Nabin Ara Neetu. I've been working as manager in a Bill and Melinda Gates funded project called Connect in Save the Children in Bangladesh. So now I would like to walk you through the medium-term question one, that is, what are the influencing factors, facilitators such as social norms, champions, cultural factors, as well as barriers, maybe family planning stigma, that influence the timing of postpartum and post-abortion family planning uptake and method selection among post-pregnancy adolescent and youth. Next slide, please. So we did a scoping review where we examined new evidence since 2015 on facilitators and barriers to postpartum and post-abortion family planning for adolescent and youth. And our review approach included HIP brief on immediate postpartum and post-abortion family planning and reference list. We also did Google search of the relevant articles since 2015. And we also included in the scoping review some were specific to adolescent girls and young women, but a lot for all ages. And also we looked at different country contexts that's like Uganda, Tanzania, Ethiopia, Kenya, Malawi, Nigeria, China, US, Bangladesh for sure, Burkina Faso, Guinea, Togo, and some global and cross-country. Some were qualitative and others were quantitative. And some propose new frameworks as well. So next slide, please. So what we found numerous barriers and facilitators identified associated with postpartum and post-abortion family planning. Some of the key facilitators can also act as barrier and vice versa. Facilitators and barriers were found at different levels, such as institution, community, interpersonal, and even in the individual level. And findings related to the factors and barriers can be used for designing test for multi-component intervention to address those factors. And many recent programs were looking at the norm changing that we were talking about in the breakout room where I was sent to, changing the level of evidence remains inconclusive with a specific focus on norm changing because most are multi-component, difficult to isolate, and many programs are tailored to context, which means it is hard to make broader recommendation, and program are seeking to change community norms, but measuring at the individual level. So next slide, please. So the result, what we found, the facilitators, facilitating factors were home visit, engaging with the community, husband, partner, and other gatekeeper supports were found as a facilitating factor. Personal agency were one of the most important facilitating factor among all those. Perceived peer family planning use behavior, last but not least, post-pregnancy family planning norms were considered as a facilitating factor. On the other hand, we found as a barriers, there are missed opportunities for information exchange throughout the continuum of care. There were provider stigma and a lack of training among the provider that was always been like forced on the method choice for the adolescent and young women. There were concern about required consent and the policy guidance, personal and others experience with side effects were also acted as barriers. Last but not least, expectations for childbearing and post-pregnancy recovery were found as a barrier. As I said, like some facilitators can be as well as barriers such as husband, partners, and family members, and some may need to be targeted with program to become as a facilitating factor. Next slide, please. So we will be looking forward in the breakout room The green one is common for all, like what degree this question been answered and what part remain to be answered. We will be focusing on that. If there are other bodies of work that are missing for answering this question, we will also have a deep dive on that question. And for this specific learning question, like facilitators and the barrier part, we will be also looking what questions should we ask next to build on this body of evidence, and how this information will be useful to influence program and policies. So now I think I would like to hand it over to my other colleague, Anna Temba, to walk you through with the next session. Thank you all.
And thank you very much, Nitu. As introduced, my name is Anna Temba, Technical Director from Engender Health Tanzania, and I'll take you through a long-term question that asks what features of service delivery points and or providers are attractive and important to young people when seeking contraceptive advice and services, and how does this influence their method choice? Next slide, please. To get to this answer, we first started by getting papers from the Full Access and Full Choice Program project, where we reviewed around 5 topics on this. And then we also did similar search with PubMed. Then through this, we were able to get like 530 titles, which were reviewed and then resulted to further review of 31. Additionally, we also reviewed HIP briefs on adolescent responsive contraceptive services, CHW, drug shop, and pharmacies, plus their reference list. So these studies included 14, which were qualitative, 13, which were quantitative, but also mixed method and systematic reviews. And 30 of these were specifically focusing on adolescents and youth. Next slide, please. So the next slide will show, a key summary of finding. And one of the key findings on the service delivery point was that adolescent and youth generally preferred services that offer privacy and confidentiality. And through the studies, we actually found that, pharmacies, drug shop, and private facilities were more preferred. The adolescent and youth found, they mostly assured the privacy and confidentiality. But it's also important to mention, most of these people who are choosing pharmacies were from urban, also a bit wealthier. And so that also had a barrier for those who are adolescents who are, on a poorer band. But also another key important finding is that adolescent and youth are particularly concerned about treatment of providers, as well as the provider bias. And, that may also result to not visiting a facility because of fear of what the treatment will be like. And this fear sometimes is experienced or expected, when you go, you face a poor service. And then also to note, because then the first two are the most priority factors, then adolescent and young people end up with those methods which are available. So as we know, in pharmacies and drug shop, majority of these are short-term, like pills, emergency contraception, and condom. So majority of adolescent and youth will end up with those methods because that is what is available. But also it's also important to note, these features might be different from adolescent based on their marital status and pregnancy experience. Next slide, please. So in the next slide, we're deep diving in the features on the service delivery point. As previously mentioned, privacy and confidentiality is key and actually affects all other features in the service delivery point. And, just to get also privacy and confidentiality, we also see differences between adolescents who are, who have had children and those who have not had children, prioritizing different things. And we'll see that in another slide. But also just to mention, at times that also identify on whether they would be like to be engaged with people like community health workers. They might also wish to move beyond their communities to be able to get the privacy and confidentiality desired. Also, another thing important to mention in terms of features of the service delivery point is that when you have multiple service delivery points, then you increase the chances of adolescents taking services. So when you are able to provide services through facility, both public and private, also within the pharmacy and drug shops, but also targeted outreach, because adolescents also, from the studies, they prefer, particularly those ones who are married, would prefer services at a closer proximity. But also we also see with adolescents who are unmarried wishing to go beyond their confinement and their community. So when you conduct targeted outreach, then you are more likely to increase service uptake. But also the service delivery working hours. So as we know, adolescents and young people also engage with other things during the weekdays, like schools, etc. So how and when are these service delivery points open and operating? So they would even actually prefer services which are being provided at 24 hours or even close late. And also that's why we also see their traction towards the pharmacy. So weekend clinics, evening hours, and also how much the waiting time it takes to get the services. But as we might imagine, for adolescents, for some of them, this is the first time they're actually interacting with the health facility or service delivery point on their own. So navigating the services might be a bit daunting. So having peer navigators or educators supporting them through having champions, contraceptive users for social assurance, but also what is happening as they are waiting for services can also increase their uptake. But also availability of wide range of methods. As we've seen, adolescents are actually accessing more short-term method because that is what is available where they want to have services like the pharmacy and drug shop. So when you have more wide range of methods available, then adolescents can take more methods, but also the range of method go hand in hand with equipment and supplies for the method. Next slide, please. The next slide will look at the features of the service providers that are attractive to adolescents. And as was previously mentioned, provider behavior is very important. Provider who is trusted and friendly. And I think we can all relate in some of the activities when you go to the field, adolescents would ask for a specific name of a provider because that's who they find trusted, but also provider bias in terms of, provider imposing their own values and statements and methods to adolescents and young people, but also provider helpfulness. So, for the adolescent or young person, this might be the first time they're actually hearing about contraceptives, and then you're giving them like an option of 12, 13 options. At times it might be hard to navigate and choose, but when the provider is helpful, adolescents tend to appreciate that. But also the provider competency in providing these services, but also ensuring adolescents and young people have a good first experience when it comes to contraceptive use is also important, because they might have a bad experience, like let's say receiving an implant without anesthesia. So that experience, they might carry it on and also pose that as a reference to other young people. But also provider competency in terms of supporting continuing users, so that also to avoid discontinuation, which is not wanted. But also respectful care would also is appreciated by adolescents, and that is respectful care based on different identities, younger versus older adolescents, adolescent with or without children, as providers tend to handle them differently, but also adolescent in school. We've also seen studies where adolescents who are in school and they come to a facility with uniform being treated differently as compared to those ones without. Next slide, please. So the next slide actually provides a summary of these features of service delivery point and provider that are important to adolescent and young people. And just to mention, as compared to unmarried adolescents and youth and married adolescents and youth, we see some few things which are different. For example, for the unmarried, privacy, confidentiality, and treatment of provider is very important. However, for the married adolescent, cost of service, distance, waiting time, and availability, available method is key. But also that also depends on, like where they would also access the services in the private sector versus the public and community health workers. The next slide, please. So in this next slide, we'll see these are the points that we're going to discuss in the breakout groups. the first two are the common questions on how much the questions have been answered in terms of the features of the service delivery points that are important for adolescent, and what that means in terms of options of methods, but also what else can we ask, what else next, and then how much will those questions be done, act differently if adoption and continuation is the outcome. Thank you very much, and I will now pass it to Eileen.
Thank you, Anna. So thank you. So this is our last question. So thank you for bearing with us. This last question was a short-term question, and it has what I would like to say has two parts. So it is who is influential, including parents, peers, community members, service providers, for example, at affecting adolescent and youth adoption and continuation of a family planning method, and how does this differ across the young person's life course? And then what I bolded, the second part of the question, which is how do we intervene programmatically to shift negative community norms at the household, community, and provider levels that poses barriers to adolescents and youth uptake and continued use of modern contraceptives. Now, I bolded that part because I feel like a little bit like the first part of the question we've discussed in that overlap piece. I'll bring that up again, but and the second part is a little bit more depth in a different area. So next slide, please. So I like to think that this learning question actually includes two questions, one that's related to the influencers and the others that's related to what do we know about successful programs to affect norms, specifically, I would say, among these same influencers. So for this review, we did a systematic search or a scoping review, and we found about 187 articles related to this topic. It is worth noting that most of the papers found were related to the first part of the question on influencers. There's a lot of information around influencers. So to supplement this information, we did a review of programs through various targeted searches, including reviewing materials on the Social Learning Collaborative site, papers and reports from the Passages Project, and a literature search that specifically was looking for social norms interventions. This helped identify program information related to shifting norms at multiple levels, such as relating to these different types of influencers. Next slide, please. So this is just a high-level summary of the findings. So first, it's worth noting that the evidence for the first part of the question on influencers overlaps with some of the other questions that we've talked about today, and I'll show that on the next slide where we dig into it a little bit deeper. Second, while this was a short-term question in 2018, because there were so many recent programs or programs at the time looking at norm change, I would say that the level of evidence still remains inconclusive with a specific focus on norm changing interventions for young people. Some of the reasons for that include that many of the programs are multi-component, which makes it difficult to isolate which types of norms we should be changing, or if we need to be changing all of them. There's also a wide variety in content, quality, and conceptual underpinnings of the programs that are out there, which again makes it so that we don't necessarily have conclusive evidence at this time. Many of the programs are tailored to context, as they should be, which means, again, it's harder to make recommendations for scaling or for spreading these types of programs. And then finally, and we'll get into these a little bit more detail, that the programs that are seeking to change social norms often are working at the community or at a higher level, but they typically are measuring these things at the individual level. So there's inconsistencies on how that's happening. Next slide, please. So digging a little deeper into the results, I'm going to do it in the two steps. So the first piece is the influencers. And again, I just want to acknowledge that this overlaps with the three other questions that we've talked about today in terms of the influencing factors on postpartum, post-abortion that need to be presented on, what features of service delivery that Anna just presented on, and the pathways question that I presented on earlier. So we do know that these groups of folks are influencing young people's young people's decision-making about contraceptive use. So parents and mothers-in-law, they may influence behaviors of young people, both positively or negatively, positively through providing knowledge or information, or negatively by restricting this information or restricting consent if that's required, for example. Parents or partners or husbands can also influence decision-making of their partners. We do know that communication between partners can increase or sometimes decrease family planning use depending on the partner's attitudes, which again, the partner is also influenced by others, including parents or religious leaders or others in the community. Peers may also provide information, positive, negative, correct, or incorrect, and they may also be sources of methods. We do know that peer pressure, including fear of peers finding out that they're pregnant, or community members finding out that they're pregnant, or peers finding out that they use, or peers encouraging use, is also important. Community members may have a collective influence, again, relating back to the norms piece. These may be through cultural or religious norms or expectations. And community members may support or not the use of a method. So norms around many things that affect these community members or religious leaders or young people, including things like age at marriage, non-marital sex, contraceptive use, fertility and childbearing. These all influence young people's decision-making. We also know that service providers may be a trusted source of information and counseling, and a positive provider experience can lead to use, as mentioned by Anna in the previous section. And married adolescents did name health workers as more influential than unmarried adolescents. They may also be they also are a key source of supplies. Service providers can also be a negative influence, as discussed earlier, as they may have provider bias towards specific methods or towards young people having sex, for example, and they may not know how to provide methods to a young person. So all of these are influencers, as well as, of course, teachers and educators may be seen as trusted resource for information, but they might also be judgmental, and they may be more important to the younger adolescents than those who are older and out of school. So some of these influencers are more or less important over the life course. So depending on if a young person is unmarried or married or has ever had children or is still in school, etc. So all of these influencers change throughout a young person's life. Finally, other factors such as lack of control or coercion over decision-making make some of these groups even more influential. All this to say that it's complicated for the influencers, but we do know there are many influencers on young people's decision-making. Next slide, please. So the second part of this question is, how do we intervene to affect these social norms? So as we discussed earlier, as David talked about, the WHO has recently updated its guidelines on adolescent contraceptive use. So as part of this process, one of the key questions that was in that guideline review was about programs that shift social norms and their impact on adolescent contraceptive use. While the guidelines are not yet public, they're still just draft, the WHO draft recommendation related to this social norm is that implementation of interventions to shift gender, age, and other social norms to support contraceptive decision-making and access to, uptake of, and continued use of contraception among adolescents and youth is a strong recommendation that has moderate certainty. So given this WHO recommendation says that social norm interventions are good to do, our question is about how should this be done to be successful. So interventions to shift social norms are often multi-component, as I'm sort of showing on this slide here. And they address these sort of multiple influencers that I talked about on the previous slide. So for example, programs happen at the school level, at the provider level, through mass media or digital media. They may happen through community dialogue, home visits, peer outreach, etc. So there's many types of interventions to influence social norms. Unfortunately, the level of evidence on which of these, which combination of these are the most effective is less available at this point, partly because they are multi-component programs. And so we do know that young people are influenced by all of these different influencers, so they should be multi-component programs, which means that the level of evidence that we need may be different than what we would want to be able to say we have strong confidence in results. So that relates back to the WHO guidelines. But because these are multi-component programs, numerous types of programs are testing different combinations of these. So that leads to a wide variety in content and quality and the conceptual underpinnings of the programs, which makes sort of understanding what works and how we should do it and how we should spread it or scale it complicated, because some components may be more appropriate for some contexts than others. And as expected, the programs are tailored to the context, which might be for married young women, for postpartum women, for couples, or for married men, for young men. And then, as I mentioned earlier, the measurement of social norms is also a challenge that makes it hard to know what works, because when these interventions are implemented, we often are measuring the norms at the individual level as opposed to measuring them at the community or at the level of the expected norm change. So to answer this question about how should we intervene to change social norms, which we think is an important programmatic recommendation, as shown by the WHO guideline recommendation, we still don't really have specific evidence on how to do this. We just know we need to. So next slide, please. With that in mind, we are going to shift to our breakout groups again. The breakout groups for around social norms, again, we'll be asking to what degree has this question been answered, which parts remain to be answered, are there bodies of work that are missing? And then the more detailed questions specific to this one are, what questions should we be asking given that social norm change is typically part of a multi-component program? And what are the implementation research questions we should be asking about social norm interventions? So next slide. So again, we're going to go into 3 breakout groups that are listed here. And we'll do the same thing, although we will not have the introduction to mural board. So with that in mind, Lauren, can you send us to our breakout groups?
Hi, everybody. We're coming back together. I know my Zoom was being a little slow and was taking a few minutes to get me back to the main room. So I'm just going to give it a minute for everyone to join, and we can go to the next slide while I introduce myself, Rachel. Thank you. And hopefully you're all hearing me well. My name is Callie Simon. Thank you so much for participating in our session today. And for all of you who are still here, we are thrilled. We weren't sure how many of you were going to hang on till the end with us, but we are glad you're here, and we hope we just have some reflections and way forward discussion that we'd like to have. As was mentioned earlier, my name is Callie. I work on the Momentum Country and Global Leadership Project, and I'm here to help move us forward. So if you could go to the next slide, Rachel. So as you know, today we have reviewed 6 of the priority learning questions that were developed under the learning agenda that Full Access, Full Choice spearheaded with many of you in 2018. And we are thrilled that we could come together today after many years have passed in a virtual format with many additional colleagues being able to join from around the world to hear really a high-level synthesis of progress on these 6 questions. So with our next bit of time, what I'm going to do is I'm going to do my best to try and synthesize some of what we've heard from you all today across all 6 questions and breakout groups. And then I'm going to talk about some of the next steps and the way forward and how we come together. And it sounds like maybe you're having some challenges with audio, but I'm going to keep going. And if folks cannot hear me, please do let me know. That's odd. Okay. So the first question we looked at is around the link between expanded method choice and adolescent youth outcomes. We looked at young people's engagement in services delivery and programming. We looked at a pathway to method choice, some of the influencing factors, features of service delivery point, and lastly, who is influential and what are the programmatic interventions? Next slide. Okay, so now's the fun part where you can see how well I did at listening and reading while you all were talking. To what degree have these questions been answered? What I heard from you all is that we've made a lot of progress actually in answering these 6 priority questions. In fact, it was impressive to me that in most of the groups, folks largely said, yeah, we've done a lot to answer the question. For many of the questions, we identified anywhere from 50 to 100 studies to contribute to that question. And we recognize that certainly is not inclusive of all the evidence out there. And it's not to say that more work can't be done. We'll come to that. But I think we should take a moment to celebrate as a community that the questions that we established in 2018, I don't think they'll be the same questions we ask now. There's many reasons for that, including the fact that our field has shifted, but also that many of you and your colleagues and coworkers have generated a lot of evidence to help respond to these questions in meaningful ways and in different contexts. And it's important that we take a moment and we celebrate, because I know for many of us in the field of adolescent health, we're doing this work sometimes with limited resources and certainly, with a fighting to prioritize these issues. And it's important that we have learned a lot. Some of the things that I know we were hearing is that we seem to have a very good set of understanding of the influencers and drivers that might motivate an adolescent to seek services, the kind of services they seek, when and if they choose to use a method, and who some of those major influencers are on the lives of adolescents. There's some excellent studies and information out there on the new method introduction issues, especially kudos to those of you working in the DMPASC space who I think have made a really intentional effort to look at adolescents as part of that learning and population. We also acknowledge that we have a lot of good experience sharing on adolescent and youth engagement, enough that it was going to be included as a good practice statement in the forthcoming WHO guidelines on adolescents, contraception and child marriage. And we also have a strong understanding of some of those factors along the method choice pathway. And I think that graphic Eileen shared that talks about the importance of life transitions, risk assessment, barriers, and method choice are really important opportunities for us to understand from a programmatic perspective. I'm also going to share a bit here on what maybe the gaps are that remain. And as I'm doing so, I would welcome you all to chat in the chat box if there are things I'm missing from your conversation, things that rose up to you as really critical to share back in this plenary space, but that maybe I didn't capture because I wasn't able to listen to all the groups. So please do use the chat box liberally. One of the things that we heard about what questions that remain, and I heard this in every single group and on every single mural board, is that while we do feel we have really robust evidence for a lot of these questions, we do not have sufficient evidence as it relates specifically to specific adolescent subpopulations and how these evidence and learning kind of can be disaggregated or is disaggregated by different populations. A lot about younger adolescents missing, especially because we know that in many contexts, ethical review boards can be very conservative and end up forcing us to work with adolescents over the age of 18. Disaggregating kind of learning by married and unmarried, adolescents, children, or one child or no children, adolescents in humanitarian settings, sexual and gender minorities or LGBTQI adolescents were mentioned several times as areas and populations where we don't have necessarily the nuance we would like to have in our evidence and learning. I heard similarly about specific geographies and contexts that we're missing in our learning. We do know from other conversations that I'm part of that a huge amount of evidence comes from a very few number of countries in our global environment, and that there are contexts that are under-researched in settings where adolescents' lived experiences and evidence is not well known. Some of those came up today, contexts like humanitarian settings and similar settings. I also heard some interesting discussion around kind of boys and the fact that a lot of the evidence that we have and the learning that we have really does focus on adolescent girls and young women. Even the questions focus on adolescent girls and young women. Boys and men are often included as influencers, which is appropriate and important. But what about kind of boys and young men as contraceptive users and as perhaps more than just influencers in this conversation? Those were the big picture that I heard across all of the mural boards. I then, of course, for each question, we had a lot of questions that remain. You know, gaps on wanting more insights around method choice and discontinuation and switching, but also acknowledging that discontinuation and switching is okay and it's a rights-based choice for young people to make, and how do we understand that? The youth engagement discussion, I think, was really interesting around the fact that we don't have evidence necessarily that says, you know, if you invest in meaningful adolescent youth engagement, then your outcomes will be improved by 10%. But also, do we need that? It's just the right thing to do to engage adolescents and youth. And maybe what we actually need is more information about the best ways to do that and more practice-based learning. I heard some really interesting discussion around the role of social media and online environments, which it seems perhaps is missing in some of the current evidence, and it may be the case of research not keeping up with realities. And then I heard some great discussion around issues of implementation. Thanks, Kate. We do need it, you say. On the youth engagement piece, I appreciate that perspective. On scale and sustainability, I heard a lot of discussion around, okay, so what does all this evidence now mean for interventions and programming, and what are the questions we need to ask next about what is the most parsimonious approaches to scale? What are the trade-offs that we need to be thinking about in intervention design to promote scale and sustainability? What is the right or appropriate or maximal dose and response that we want to see in terms of program interventions? And some questions related to issues around platforms. So, you know, what can we reasonably expect health systems to scale, and what are the other platforms that we need to be investigating? So a lot of new questions on implementation, intervention design, research that can contribute directly to scale up and sustainability. I'm going to wrap up with one more thing, which is the what other themes emerged. So in addition to all that we discussed, I also saw some really interesting questions being posed around what counts as evidence and what counts as research. And certainly this was a huge discussion in the WHO guideline development process, where they have very strict requirements for research and evidence. In this review that Eileen and her team have led, they were broadened out that quite a lot and captured a lot of qualitative learning, a lot of additional evidence. But I think we still need to grapple with this idea of what counts in our world as evidence, and how can we broaden out that definition to capture, you know, more around youth-led research, youth perspectives, and evidence that can help guide decision making. And similarly, there was a call for making sure we think carefully about the indicators we use, and perhaps shifting our thinking from sort of a focus on uptake to more around measures that account for fertility intentions and the priorities of adolescents and youth. Please chat in the chat box if I missed some really critical points that you want to be sure are shared in plenary. We will continue to read these mural boards, capture all of what you're saying. So that nuance will not be lost, but if there's things you want to be sure we bring up here in plenary, please put it in the chat box. I'm going to move to the next slide now, which is about next steps. So where do we go from here? Well, as you've heard us mention, we are interested, and by we, I mean many of you on this call, in developing an updated global learning agenda. Next slide. The global learning agenda that we would like to update would take forward the discussions we have today to identify what are the priority questions that we as a community want to answer on adolescent contraception, going beyond method choice to include access choice, equity, quality, and other rights-based issues. Why do we think we need to have an updated learning agenda? Well, we believe that a learning agenda that we all collectively contributed to and that is available publicly can help to promote all of us to work together. It can help prioritize donor investment. It can help reduce duplication of effort. And hopefully it can help us all contribute to those priority research questions that we think will really drive the field forward. Next slide. So how are we going to put this together? I've put here a very high level set of steps that we are anticipating taking. And the first step would be to form a diverse advisory group. So I should make clear that we at Momentum Country and Global Leadership have committed to helping take this work forward with the support of USAID. Thank you very much. And we are in a position where we're going to be able to guide us, but we certainly want this to be a very participatory approach with a diverse set of perspectives, including from adolescents and young people themselves, researchers, implementers, ministry officials, donors, representing a diverse set of geographies around the world. So we're going to form a diverse advisory group and create a set of criteria that will guide our prioritization of questions. We will distribute a survey to all of you and many others to gather your ideas for key learning questions to take forward. And then we'll develop a consolidated list of questions that will combine inputs from the survey. The inputs that you've given today on the mural boards will appear in that consolidated list of questions, and recommendations coming from the WHO Guideline Development Group. You've heard this group mentioned many times. I'm hopeful that Sherry can provide a bit of context on this towards the end, but in the guideline development process that's been ongoing over the last year or two, there have been a number of questions raised for future learning and evidence generation. And we're going to take those questions and combine them with the ones we're generating today so that we have a cohesive set of questions across the field. We do intend to convene 2 to 3 virtual consultations to then discuss and refine the learning agenda questions in a variety of different times and languages. And then at the end, the advisory groups will help score the final questions against the criteria established, and the highest scoring questions will form the learning agenda. We anticipate taking this work forward starting now through till likely early 2025 to make sure we have enough time for everyone to participate and engage meaningfully in the process. We would very much welcome all of you to engage. We are going to be reaching back out to you at key moments, but in the meantime, if you have a lot to say about how we should develop this agenda, if you want to be part and parcel of the work, if you feel strongly that you or someone you know want to be on the advisory group, I welcome you to reach out to me. I'll put my information in the chat box, and we would be happy to take on board your ideas and suggestions as we move forward together. Next slide. With that, I'm actually going to pass back to Sherry to wrap us up for the day today. Thank you all so much for your contributions, and we look forward to working with you as we develop the next iteration of our global learning agenda.
Great. Thank you so much, Callie, for a succinct synthesis of today's discussions, distilling the key takeaways, as well as walking us through the next steps. Very much appreciated. I completely agree with Callie that it's important to acknowledge and celebrate the progress we've made in the field, while at the same time focusing our efforts on raising the bar going forward so that we can make strides towards filling key evidence gaps as we further develop and hone the learning agenda. Just to address the comment by Callie about the updated WHO guidelines, I can share that we are currently in the process of finalizing the guidelines with an intention of wrapping up in the second quarter of this year. So stay tuned for the launch of the updated guidelines. And as we bring our workshop to a close, I want to first extend my deepest gratitude to all the speakers and facilitators for their fantastic contributions to the workshop and making it all happen so seamlessly. I have to say, I think the mural boards really served as a great collaborative brainstorming tool that worked particularly well. And the PDFs of those boards will be a great resource for capturing the discussions. We would again like to extend our thanks to the Bill and Melinda Gates Foundation for supporting the work to date through the Full Access, Full Choice project. We would also like to express our appreciation to WHO-HRP for their continued engagement. Similarly, the support from USAID through Momentum Country and Global Leadership has truly been instrumental and underscores a shared vision for a future where young people worldwide have the means to make informed choices about their reproductive health. And in terms of next steps, as mentioned, we will be sharing the slides, a recording of this session, PDFs from the mural boards, and a list of references reviewed for the 6 questions with all participants. As Eileen mentioned, we will also be reaching out to ask if you have inputs to any of the priority questions or sub-questions that you may not have had an opportunity to discuss today. So please keep an eye out for that. We really want to hear from you on all the questions. And in closing, I just want to reiterate again my thanks to each and every one of you for your participation. I think the discussions today have been extremely rich as a result of the high levels of engagement. I hope everyone's enjoyed the virtual workshop and that you will have come away learning something new or having identified a gap that you feel particularly committed to addressing in your work, for instance. So I hope we can continue to build on the momentum we've generated as a first step in the process to develop an updated global learning agenda on adolescent contraception access and choice. Grateful thanks again to everyone for a dynamic and insightful workshop. We look so forward to being in touch as we progress on next steps. And take care, everyone. Many thanks for your contributions again, and all the very best on the behalf of all the organizers and contributors.